what is the role of beta blockers? That's what we discuss here. But we have to understand one thing, that cirrhosis can have varied presentation. It is child A, B and C. Patient can come with absolutely normal LFT, can have jaundice, ascites, renal failure and hepatic encephalopathy, and all of them can present with bleed. So definitely it's not possible that beta blockers equally benefit everybody. Are the beta blockers most effective drugs, or is there a flip side to the coin also? So with that topic, we'll discuss the role of beta blockers in prophylaxis, pre-primary, primary and secondary prophylaxis, and what is the flip side of beta blockers. So I will leave the topics in the following headings. Coming to the natural history of varices, as you can see, patients' cirrhosis can come with ascites, without ascites. Patients with ascites are in advanced stage of cirrhosis, so they will have higher propensity of varices. 60 to 70% may have varices, and obviously varices can be small to large and can have a rate of bleeding varying from 7 to 25%. And obviously each bleed is associated with high degree of morbidity and mortality. Morbidity and mortality within 1 week can vary from 5 to 8%, which can go to 20% to 60%. The mortality can be because of bleed, can be because of complications due to bleed. That may happen. Once the bleed happens, blood pressure further comes down. So there is an ischemic insult to the liver that will increase the SGPGI and obviously worsens the liver functions. So this is a simple cartoon that we try to help you understand how good or bad are the hemodynamics that are altered. Normally, patients, when he is compensated, he has a normal effective blood volume. But liver acts as a dam when it becomes cirrhotic. The dam is built on portal vein. So once the blood flow from the portal vein to the liver is compromised, there is increased back pressure of the blood, leading to gut congestion, engorgement, formation of varices. This would lead to gut congestion and increase bacterial transformation active oxide, which worsens the splanchnic and also the systemic circulation, leading to vasodilatation of both splanchnic and systemic. So this would further reduce the effective arterial blood volume. So the blood volume decreases as cirrhosis progresses. So this is what constitutes the portal hypertension, and we'll discuss the drugs that are used in portal hypertension. So portal hypertension related complications like upper GI bleed in acute setting, it's important to manage the bleed, and the drug used at 30% it's the chronic setting in which we have to give prophylaxis to the patient. Do we need beta blockers? So chronic therapy for portal hypertension related complication, beta blockers play a role. So beta blockers can act on beta 1 and beta 2. Beta 1 reduces the cardiac output. Beta 2 causes splanchnic vasoconstriction. Cirrhosis, we have vasodilatation. We require splanchnic vasoconstriction to push more blood into the circulation. Then we have alpha-1 antagonist. For example, carvedilol is a non-selective beta blocker, but it also has alpha-1 antagonistic action. This is important to reduce the intrahepatic resistance. Intrahepatic resistance, 30% is dynamic, and that can be reduced by carvedilol. It also reduces the collateral vascular resistance. Overall, helps improve the liver blood to reduce portal hypertension. So this cartoon shows what all beta blockers can do. It can reduce the heart rate, cardiac output, decrease venous blood flow, reduce splanchnic vasoconstriction. And in the last there is a red circle with alpha that is basically for carvedilol. It also reduces the systemic vascular resistance. So carvedilol may not be as effective as disease progresses, because as cirrhosis progresses, because of splanchnic and systemic vasodilatation, the blood pressure comes down. If you see a cirrhotic patient, the blood pressure may be 90/60. It may not be 120/80 that we commonly see in our patients. It is because of combination of splanchnic and systemic vasodilatation. So that is why in advanced cirrhosis, if we give carvedilol, there is a possibility that systemic vascular resistance may further come down and hemodynamics may further worsen, increasing the renal complications. So anyway, to start the disease, HVPG 0 to 5 or the portal pressure, that HVPG that we calculate in cirrhotic patients with a Schwann-Grenz catheter. Normally it's from 0 to 5, but as cirrhosis progresses, it keeps on increasing. When the hepatic venous pressure gradient becomes more than 12, more and more complications of cirrhosis happens. So our basic aim is to prevent increase in portal pressure, but if the portal pressures have increased, to prevent decompensation. Now we look at the role of beta blockers. Beta blockers can have pre-primary prophylaxis role, primary prophylaxis and secondary prophylaxis. What is the difference between the two? So pre-primary prophylaxis, when HVPG is more than 6, but patient does not have varices on endoscopy, or HVPG is more than 6 but has a very small varices. So basically this means that the risk of bleeding is minimal due to esophageal varices. So beta blockers and this, do they help or how do they help? So studies have been done in patients with small varices or no varices. That was more than 200 patients that was taken in. And they found that in pre-primary prophylaxis, when there are hardly any varices, there is no difference in rate of formation of varices, progression of varices, formation of ascites, altered sensorium like encephalopathy or liver transplant. So basically, when there are no varices or small varices, beta blockers may not help much. But a recent study that has contraindicated, it has smaller number of patients, only 161 compared to 273. They found that over a period of 3 to 4 years, it may cause some decrease in formation of varices by around 10% or so over a period of 5 years. So jury is out that do we need to give beta blockers in pre-primary prophylaxis? There might be a benefit of up to 8 to 10% in over a 5-year period. Coming to primary prophylaxis happens when the disease is advanced, patient has large varices, and here beta blockers do definitely have a role. It can be done by endoscopy to find out, or a normal fibroscan that is normally available. If the values are high, obviously you can, with low platelets, you can expect that the patient may require primary prophylaxis. I'll come to cutoffs of each with subsequent slides. So once the patient has advanced cirrhosis, he has high scan values on fibroscan. It's more than 25. Platelets are less than 1 lakh. Then obviously he has high risk of formation of varices. You can do endoscopy to confirm. Once you know that patient has grade 2 or more varices, then beta blockers here do definitely reduce the risk of bleeding and reduce the risk of progression of varices. Now, can we ban the varices instead of giving beta blockers? So studies have found that for primary prophylaxis, if the patient has not bled, but he has come to you and has large varices on endoscopy, if you just give beta blockers, the result is as good as banding. So you can reduce the complications of banding and improve the hemodynamics once you give beta blockers. Impact on mortality is similar as you do for banding. So banding may not help if the patient has not bled, and beta blockers are equally effective. Multiple studies have been done for choice of beta blockers. We have propranolol and carvedilol available. In a nutshell, patient has good liver function. He has not decompensated. So decompensated means patient comes with jaundice, he has ascites, he has recurrent infections, or has bleed, or has altered sensorium, hepatic encephalopathy. If the patient does not have any of these 5 things and has good liver functions but is cirrhotic, carvedilol is the drug of choice. As the disease progresses, patient develops decompensation. In the body, hemodynamics get altered. You have increased plankning, systemic vasodilatation, reduced systemic vascular resistance. Here, because of alpha-1 antagonism, Carvedilol may reduce renal blood flow further. So if you want to give prophylaxis, here propranolol might be a better choice. Now the patient has bled and you have secondary prophylaxis to cope with. So for secondary prophylaxis, again, beta blockers and banding have comparable efficacy. Here, beta blocker and banding and not beta blocker versus banding. You have to do banding. So beta blocker and banding of the varices are much useful than banding alone or beta blocker alone. They help to reduce overall mortality. Now we have multiple studies for prophylaxis that have shown that this is comparison to placebo, not with banding. That if you give beta blockers versus placebo, beta blockers outscore placebo almost double the benefit than what placebo gives. So with banding and beta blockers are superior to placebo or beta blocker alone. Now, which beta blocker to use? Carvedilol or propranolol? That is a question that we physicians do worry. So, coming to carvedilol and then I'll come to propranolol. Carvedilol is in addition to propranolol has alpha-1 antagonism action. Studies have shown that if you combine carvedilol with banding, there are fewer bleeding events in carvedilol group compared to banding groups. The dose of carvedilol is 12.5 mg per day. 3.125 mg is a tablet that comes, so you can give up to 4 tablets a day. Higher dose than 12.5 does not help. Follow 2 years, up to 2 years has shown that carvedilol, if you start early, does reduce the risk of decompensation. And previously shown if you give carvedilol over propranolol, the last one, frightening vasodilation and decreased total blood flow, is slightly better in patients who have not decompensated because of carvedilol. So studies have shown that carvedilol does improve mortality. It significantly decreases the risk of developing decompensation, as you can see in the top graph. In the lower graph, it obviously has shown to improve survival significantly. There are very few drugs that help in cirrhosis, and beta blocker, especially carvedilol, is one of them. It helps improve survival. Coming to comparison of head-to-head carvedilol versus propranolol, carvedilol has been found to be superior. If you look at the studies, carvedilol may have double the benefit compared and on reduction of mortality compared to propranolol. This was one study in which carvedilol was given to people who failed on propranolol, that is the SGPGI did not decrease. Here also, propranolol failure benefited from carvedilol as the rate of bleeding of over 2 years follow-up was less than half of what the propranolol group had, 5% versus 11%. For secondary prophylaxis, when the patient had bled, again carvedilol showed higher hemodynamic response and lower bleeding. So NE and BID study for pre-primary, primary and secondary prophylaxis, if the patient has not decompensated enough, carvedilol is better than propranolol. Multiple studies have shown the same thing. Meta-analysis also has shown that higher incidence of decrease in HEPG because of carvedilol group compared to propranolol. Carvedilol compared to all other beta blockers, nadolol, propranolol or placebo, carvedilol has shown superiority. So in a nutshell, which and when to choose beta blockers in cirrhotics? This is a table. Pre-primary prophylaxis, level 1, grade 1 indication for beta blockers. For prevention of decompensation, again grade 1, level 1B recommendation for beta blockers. For prevention of first varicose bleed, level 1, grade 1 indication for beta blockers. Prevention of secondary prophylaxis, level 1 indication for beta blockers. For gastric varices progression, now gastric varices are definitely not completely linked to HEPG. So here the recommendation is slightly good, it is grade 2, but more useful than placebo. Coming to portal hypertensive gastropathy, another complication of bleeding. The indication is again level 1, grade 1 indication. So this in a nutshell is the use of beta blocker or recommendation of beta blockers in cirrhosis to prevent bleed and after bleeding. Now that brings us to the condition that should all cirrhotics be treated with beta blocker. As we discussed, beta blockers may not help too much once the disease is advanced. And why is that? That is because beta blockers reduce the cardiac output, reduce the renal perfusion, and reduce the risk of and increase the risk of developing HRS. Now, because of splanchnic and systemic vasodilatation, the renal blood flow is compromised. This body perceives as a hypovolemic state. There is no blood loss. But because of splanchnic and systemic vasodilatation, kidneys assume that it is a hypovolemic state and they try conserving water and sodium. This leads to formation of ascites, large ascites, refractory ascites, ascites with development of AKI, renal failure, hepatorenal syndrome. So the pathophysiology starts with decreased renal blood flow. And in advanced cirrhotics, beta blockers can further reduce the systemic vascular resistance, decrease renal blood flow, may form ascites, develop HRS or refractory disease. So that is the problem with beta blockers in advanced cirrhotics. That's what that said will be written. But many studies had previously shown a lot of benefit. Look at the CTP score of these patients. They were much less advanced with almost absence of ascites in most of them. Original studies had limited patients with ascites and had early stage of cirrhosis. This is what happens. This is just a cartoon that I built to show that when it's in advanced stage, the cardiac whitening comes down. There is central hypovolemia that develops, and this beta blocker may worsen. So here, giving beta blocker may reduce the effect of beta blockers. That brings us to the situation of when to stop beta blockers. This again will be discussed in the hemodynamic issues. Once you look at the hemodynamics, how to look at important markers of hemodynamics. First of all, clinically has the patient decompensated. On beta blockers is the ascites worsening, is the urine sodium decreasing. If you have a Doppler, you can just do a renal artery resistive index. Very easily done. A resistive index can be done for any vessel. Renal artery resistive index is more than 0.7. Is a 24-hour urine sodium excretion less than 80 millimoles per day. If you are doing echo, look at systemic vascular resistance. Is the systemic vascular resistance less than 1200? Basically, it can come down to as low as 500. So all these parameters suggest that it is difficult to increase the dose of beta blockers or continue beta blockers. So many clinical parameters for us to assess on a day-to-day basis when patient comes to us. And all these are clinically available, there are no hi-fi tests involved here. So, role of beta blockers in cirrhosis, when to stop end-stage cirrhosis. When patients have refractory ascites, AKI, there is here the issue with end-stage cirrhosis is beta blockers may increase the mortality. This whole concept is called window concept. So the window is open for a small amount, the patient is compensated, has risk of bleeding. But as the disease progresses, the window closes. Now we can't give beta blockers. This closes when the patient has refractory ascites, systolic TP is less than 100. The MAP is less than 82. There is AKI, hepatorenal syndrome. The ascitic fluid is infected. There is sepsis, and there is poor medical follow-up. When you know patient has come from far-off area, he is already decompensated. We don't know that he may develop AKI at home and may not survive. Then obviously the risk outweighs the benefit. So this window concept is there. Now I'll just give some evidence quickly and wind up the talk. MAP more than 82, better survival. MAP less than 82, poor survival. Stop beta blockers. Cardiac index less than 1.5 versus more than 1.5. Less than 1.5 beta blockers harmful, increase mortality. Stop beta blockers. Development of AKI and severe, if patient has AKI, severe hyponatremia or refractory ascites, stop beta blockers. Here the mortality is much higher. Again, refractory ascites with refractory and non-selective beta blockers worsens AKI and hyponatremia. Better to stop beta blockers. If you are doing large volume paracentesis, what happens? Inability to increase the cardiac output. Better to hold or stop beta blockers. You will only do large volume paracentesis when diuretics are not healthy. So stop beta blockers. Development of AKI hepatorenal syndrome, stop beta blockers. If the patient has spontaneous bacterial peritonitis, stop beta blockers. If the patient has AKI would worsen, stop beta blockers. Now, if the patient has severe alcoholic hepatitis, the risk of development of AKI is much higher in severe alcoholic hepatitis when you add beta blockers. Therefore, stop beta blockers. The disadvantages of beta blockers, as already been mentioned, are summarized in this table. Low cardiac output, low MAP, increased RA-RI. Better to stop beta blockers as the mortality is much higher in patients taking beta blockers. Large ascites, you can continue beta blocker, not a contraindication, but be cautious that he is mobilizing the ascites on the ureters. Avoid higher dose. If it is not, that the ascites becomes refractory, be very, very cautious or stop beta blockers. In acute or chronic liver failure, a recent study has shown that beta blockers may be equivocal, may not increase mortality. And this was basically because the patients who had improved survival had lower WBC count. They might have had less inflammation, less gut congestion and hydroxemia leading to this. But in all of other studies, it's better to stop beta blockers when you are developing complications of cirrhosis. Now with beta blockers, what happens to portal vein thrombosis? The risk of development of portal vein thrombosis increases 4 times because there is the liver acts as a dam. The portal blood flow velocity decreases. It may reverse from hepatocrital, it may become hepatocrital. So as because of congestion in the liver, decrease in velocity, the portal vein may thrombose. And this is increased in patients taking beta blockers. So in a nutshell, where to use beta blockers? Consider using beta blockers in end-stage liver disease with very close monitoring. If it is not possible, do endoscopic variceal ligation and stop beta blockers. Beta blockers should be reduced or discontinued if the systolic BP is less than 100, preferably less than 90, definitely. Hyponatremia, development of AKI. Patients with small varices or no varices, beta blockers are not indicated. These are the recommendations summary for beta blockers. If development of ascites, refractory ascites, hypotension, SBP, AKI, ACLF, better to hold beta blockers or be extremely cautious about it. Bevino 7 also recommend for when to start beta blockers. Bevino 7 gives the recommendation, but when to stop already we have.
Thank you very much.